Good day everyone, I am Mr. Lord Christian C. Havana from BSN 3A, and today I will be discussing a very important topic in perioperative nursing care. These are the common emergencies in the operating room, specifically anaphylaxis, cardiac arrest, and equipment malfunction, and the vital role that the nurses play in each situation. The operating room is often seen as a place of precision and control, but the reality is that emergencies can happen without warning. Even with the best preparation, a patient's condition can suddenly change, and when it does, the ability of the OR team to respond quickly can literally save a life. During my OR duty, I realized that emergencies are not just TV drama moments. They are real, sudden, and require immediate action. Even the most routine surgery can turn into a high-stakes situation if an allergy develops, the heart stops, or an equipment piece fails. In this report, I will discuss each of these emergencies in detail, explaining the nurses' roles in managing them and connect these situations to actual OR observations or real-life examples. First, let's discuss anaphylaxis. Anaphylaxis is a severe life-threatening allergic reaction that can occur in seconds to minutes after exposure to a trigger. In the OR, common causes include anesthetic drugs like propofol, certain antibiotics, blood products, and even latex from gloves or catheters. When anaphylaxis happens, the patient's immune system overreacts, causing massive histamine release. This leads to a sudden hypotension, airway swelling, bronchospasm, and sometimes skin rashes or hives. Without immediate treatment, the patient can go into shock and die. Now let's talk about the nurse's role in anaphylaxis. First, there should be an early recognition. A circulating nurse should constantly observe for sudden drops in blood pressure on the monitor, changes in skin color, or any sign of difficulty breathing. Next, there should be an immediate action. Inform the anesthesiologist and surgical team at once. Stop the suspected allergen and prepare emergency drugs like epinephrine and antihistamines. Next, there should be airway support. We need to assist in oxygen delivery, prepare for possible intubation if airway swelling is severe. Lastly, there should be documentation. We need to record everything, such as the signs of the interventions, the medications given, and the patient's responses. Now let's consider an OR example. In one hospital case I read about in an article, a patient undergoing cataract surgery developed anaphylaxis within minutes after receiving IV antibiotics. The circulating nurse noticed the sudden rash on the chest and arms before the monitor even showed low blood pressure. She immediately alerted the anesthesiologist, prepared epinephrine, and ensured the crash cart was beside the patient. The quick recognition and actions here saved the patient from going into cardiac arrest. From my own OR observation, I saw how nurses always check for allergies before surgery. Even if it seems repetitive, it is a life-saving habit. One scrub nurse even double-checked the label of a drug after seeing penicillin allergy on the cart. A simple act that could have prevented an emergency. Next, we have cardiac arrest. Cardiac arrest in the OR is when the heart stops pumping blood effectively. This can be caused by massive bleeding, complications from anesthesia, severe allergic reactions, or a pre-existing heart condition. When cardiac arrest happens, time is critical. Brain cells start dying within 4 to 6 minutes without oxygen, so every second counts. Now let's talk about the nurse's role in cardiac arrest. First, we need to call for help and activate Code Blue. The circulating nurse should immediately alert the entire team and the nearby units. Next, we need to start BLS. If needed, Start chest compressions until the anesthesiologist takes over airway management. Also, we need to prepare and hand over emergency medications such as epinephrine or amiodarone as per advanced cardiac life support protocol. Next, we need to ensure that the defibrillator is ready. We need to place pads if indicated and assist in delivering shocks. Also, we need to coordinate with the surgical team. Sometimes, the surgeon must stop operating to focus on resuscitation. A true case shared by one of our CI nurse involved a middle-aged patient undergoing abdominal surgery. Midway through the procedure, the patient developed severe bradycardia and went into cardiac arrest. The scrub nurse stayed sterile but handed over necessary instruments for emergency thoracotomy, while the circulating nurse activated code blue, started compressions, and brought the defibrillator. The patient was revived after 3 shocks and high-quality CPR. In my OR duty, I did not yet witness cardiac arrest, but every morning, the circulating nurse checked the emergency crash cart, making sure that the defibrillator worked and medications were in date. This habit is not just a routine checklist, it ensures that if the unthinkable happens, every second is spent saving the patient, not searching for supplies. Next, we have equipment malfunction. Equipment malfunction might sound less dramatic than the first two, but in the OR, a single failure can lead to life-threatening consequences. Examples include an anesthesia machine failure, electrocautery malfunction, or a suction machine breakdown, or even a broken light source during a delicate procedure. Let's talk about the nurse's roles in equipment malfunction. First, there should be a pre-use checks. Before the surgery, we need to start and test all the machines to ensure that they are functional. Also, we need to troubleshoot quickly. If a malfunction happens mid-surgery, immediately inform the team, switch to backup equipments, or use manual alternatives like hand ventilation. Also, documentation and reporting is necessary to prevent repeat occurrences. In cases where an anesthesia machine stopped delivering oxygen mid-surgery due to a faulty valve, the nurse should quickly switch the patient to manual ventilation while the anesthesiologist fixes the issue. Without this quick action, the patient would have suffered brain injury from lack of oxygen. In my OR exposure, I observed nurses testing the electrocautery before the surgeon arrived. They would also check suction strength and lighting. At first, I thought it was just part of a pre-op ritual, but I realized it's actually a preventive measure against dangerous equipment failures. In conclusion, emergencies in the OR, whether it's anaphylaxis, cardiac arrest, or equipment malfunction, demand more than just medical knowledge. They require preparedness and rapid action and teamwork. Nurses are often the first to notice a problem and the first to act, making them essential in protecting patient safety. From my OR exposure, I learned that prevention and preparation are just as important as the actual emergency response. Checking allergies, testing machines, and inspecting the crash cart may seem like small tasks, but they are acts of vigilance that can save a life. In the OR, there is no room for hesitation. Every second matters. And for us nurses, being alert, ready, and decisive is not just part of the job. It's part of our responsibility to the patient's life. For my references, I use Alexander M. Rothrock J. Baker J. in 2023. This is all about their Alexander's case of the patient in surgery, 17th edition. Also, I used Miller and Pardo in 2021, Basics of Anesthesia, and the World Health Organization in 2022 about safe surgery checklists and patient safety resources. Thank you.